Good day and welcome back. There was a NEET recall question where tuberculosis and HIV was asked, and the drug that is contraindicated, a tuberculosis drug which is contraindicated when a patient is taking antiretroviral therapy. So that set me thinking, why don't I talk a little more about lymphadenopathy, and that too TB lymphadenopathy in a case of HIV. So as I said, the collections are from my personal collections and patients have given consent. Again, I keep putting disclaimer that these are my personal photographs, but these clinical online platforms should not be a surrogate for the actual clinical encounter of patients and working in the facilities, healthcare facilities. So now let's come down to the clinical scenario as such. This is a 55-year-old patient diagnosed to have HIV and started heart treatment 1 week ago, after of course ruling out latent or active tuberculosis. He now presents with lymphadenopathy. There are no constitutional symptoms. The likely causes. Look at this huge lymphadenopathy in the axilla. Not only that, see the florid skin reaction to the underlying nodes. This is how TB lymphadenitis in HIV positive patient usually presents. So when you have adenitis like this and patient is HIV not yet tested, please, most of the time they will be positive. So your options are, is it tuberculosis, infectious mononucleosis, lymphoma, or an immune reconstitution inflammatory syndrome? Now, the clue is 1 week ago. See, just 1 week ago. So it's an immune reconstitution inflammatory syndrome. So the right answer is this. So the clue is within 1 week, immediately after starting an HRT. Keep this in mind. If somebody is given you the time, that means they are looking for this answer. Fine. They are looking for IRIS. And not only that, they give you another clue saying no constitutional syndrome, no constitutional symptoms. You see how they are giving you clues to push you into the right option. So always read the clue. When you have 2-3 points ticking there, that means it's helping you navigate and come to the correct option. Now this patient is diagnosed to have HIV and he was started 4 months ago. See now, the same patient, I've changed the history a little bit. I've made it 4 months. He now presents with lymphadenopathy in the axilla. There are no media. Naturally, when they have this lymphadenopathy, you will also look into the chest and abdomen. You might do a CT. There are no mediastinal and retroperitoneal nodes on imaging. There are no constitutional symptoms. The likely cause is all of the below except, let's have a look, pneumocystis carinii, lymphoma, Kaposi sarcoma, TB, none of the above. Let's see what I want to tell. The axilla is a superficial group of nodes. When you have deep group like your mediastinal or your para-aortic in the abdomen, think of malignancy and infection. So the answer actually is malignancy and infection. All of them belong to one or the other. When they are superficial nodes, think of reactive nodes. This is important. So here they gave you a clue about reactive nodes based on the clinical and the imaging findings. They pushed you there, but they have not given you that option. So it is none of the above. See now. So it's not only the time within 1 week after starting ART. No, it can be months later. So that is why you need to know whether it is superficial or deep nodes which are involved for you to get the right option. Now, we have added one more layer to this clinical scenario, and these are very practical scenarios. This is what you would do when you get an HIV patient with lymphadenopathy. There's nothing theoretical about it. Okay, so his CD count is less than 50 cells. The nodes are likely to be all of these except. Have a look. You have a mix of both your infection as well as your malignancy. So how do you tease it out? In this itself, you must be able to tease out based on the CD count number. Look here. If the CD count is more than 200, then it's likely to be bacterial or viral. For example, your infectious mononucleosis or a Pseudomonas pneumonia. If it is less than 200, then all fungal infections will come in and your pneumocystis carinii. If it is less than 50, your malignancy will start appearing. So, what all is CD count is less than 50. So, he is likely to have malignancy. It doesn't mean that these will not be here. They will also move in here. So, your infectious mononucleosis is unlikely because his system will be attracting more serious infections. So, the answer will be your infectious mononucleosis. Not because it cannot be there, but the system will be attracting more serious problems. Now, you have done a biopsy. It has come as tuberculosis. All are true of this clinical scenario except there was a recall question asking for one anti-tuberculous drug which is contraindicated in your HIV patients. So that is why I made these slides. But I thought I'll pull in some more of clinical stuff there. So once weekly INH and rifampicin in the continuation phase should not be used in any patient infected with HIV. Okay, let's keep it at that. 4 months should be considered the minimum duration. Treatment of drug-resistant TB is the same as that of normal patients with TB when compared to HIV patients with TB. It is the same combination. You need not escalate the drugs. For patients who are HIV but not started ART yet, they develop tuberculosis, you will be initiating it at the same time as that of the TB disease. So HIV treatment should also start with the TB disease. Is there an exception to this? Let's have a look. Now, is it really 4 months? Let's see the right answer. It is 6 months. And this is very much right. I'm just adding one more pointer there. You usually start same time except when there is meningitis where you will start HRT a few weeks later. So that is it. I just very specific lymph nodes in HIV and I'll try to make some more on lymph nodes in HIV because these are the persons who will be landing up with the surgeon. And I basically started off, the trigger point was the chemotherapy in pharmacology, which they had asked in the recall. And thank you very much. I'll keep, as usual, ask you to subscribe, share and like. Please do stay invested in this particular channel because I'll be bringing 99% a very clinically based approach, clinical concepts and clinical images from my own collection. Thank you.